Okay.
Good. Okay. The October 13, 2020 Board of Education regular workshop meeting will now come to order. Mr. Guzman and Mr. Curry notified the superintendent that they would not be able to be in attendance at tonight's meeting. May I have a motion to allow Mr. Guzman and Mr. Curry to? Oh, I'm sorry. I did not see my mistake. Let's do a roll call then, Ms. Moog, please.
Here.
Here. Here. Here. Okay, there we go. Let me repeat for the record. Mr. Guzman and Mr. Curry notified the superintendent that they would not be able to be in attendance at tonight's meeting. May I have a motion to allow Mr. Guzman and Mr. Curry to participate by phone for tonight's meeting?
Motion.
Second.
Any discussion? Roll call, Ms. Moog?
Yes.
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 Yes. All right, and we will do roll call one more time. Thank you.
Mr. Guzman?
Here.
Mr. Curry?
He's getting there.
Here.
Mr. Lobach?
Here.
Mr. Esty?
Here.
Mrs. Butterman?
Here.
Dr. Bruno?
Here. Mr. Lowak, will you lead us in the Pledge of Allegiance, please?
Yes. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Ms. Moak, I don't need to do roll call again, correct? All right, we're good. All right, well, then we will go right to public participation. Members of the public who wish to address the board should check in with Mrs. Moak, the board recording secretary. Speakers are asked to be respectful to quorum and limit comments to 3 minutes or less. Mrs. Moak, is there anyone wishing to make public comment? Thank you very much. Next item is the consent agenda. Are there any items board members would like to be removed from the consent agenda to be considered separately? Hearing none, may I have a motion to approve the consent agenda, which includes the open and closed session meeting minutes of September 28, 2020, and the personnel report, which includes employment recommendations, leave requests, and resignations as presented.
Motion.
Roll call, please.
Mrs. Buttermer?
Yes.
Mr. Estes?
Yes.
Mr. Guzman?
Yes.
Mr. Lobach?
Yes.
Mr. Curry?
Yes.
Dr. Bruno?
Yes. Okay, thank you very much. Then we will get right to our 2021 District 41 reopening school plans update, and I will turn it over to our superintendent, Dr. Kaskowski.
All righty, thank you. I'm going to do a little shift and reorder our topics for tonight because we have Dr. Matthew Phillip from DuPage Medical with us tonight. Dr. Phillip is going to talk to the board about COVID-19 surveillance testing. Before we turn it over to Dr. Phillip, we're going to have our advisory team give an update on the metrics, which will make, I think, a very nice lead into some of the information that Dr. Phillip is going to share with us. And then after Dr. Phillip is done, we will have a special education update from Laurel O'Brien and a staffing update from Marcy Conlon. So before I hand it over to Katie and Ellen tonight, just want to remind everybody that they have been instrumental in bringing their medical and scientific expertise to our committee. For the past several weeks, DuPage County has lived in moderate transmission risk designation, or orange, according to the DuPage County health metrics. Unfortunately, our update tonight is a little bit of a sobering one. As a county, 2 of the key metrics have been moving in the wrong direction and may cause the county to be moved into the substantial transmission risk, or red designation. As everyone is aware, we get a tentative update on Friday and the county posts their official metric summary on Monday. So I'd like to remind the board and our audience that if we move into red this Friday, we will alert our families via email. We'll continue to monitor the data and wait for next Friday, which would be 10/23, to receive the next update from the county health department. If we remain in red at that point, with the guidance of the health department, we could be considering a move back to full remote, possibly as soon as 10/26. But Again, that'll be done as a county with other superintendents and with the DuPage County Health Department. We will, as promised, aggressively communicate this with our families in the event that the district does have to implement our full remote model. So I'm going to turn it over to Ellen and Katie to talk through the latest metric update.
Welcome, Katie and Ellen. Nice to see you here.
Nice to see you. Thanks for having us. Never pass up hand sanitizer. I'm sorry.
There you go.
All right. Okay, I'm gonna go through this a little faster than last time. You already
seen it
know.
before.
This is our team though, me, Ellen, and then David and Kathy who aren't here tonight. We went over the methodology last time, so I'm gonna just click through this. But if you have any questions at the end, just have an ask. We wanted to, this is new since last time. It's not new, but it's something that we didn't discuss last time, adaptive pause from IDPH. So this was put out by IDPH on August 17th. So this goes over all the different ways that school districts in Illinois can pause to get a hold of community transmission. Obviously, we haven't even had students in school yet, and numbers are already heading in the wrong direction, unfortunately. But this goes over how you can close just a classroom if there's 2 cases in the same classroom. If there's a transmission within a grade level, that's an option too. Some buildings may need to individually close, or we might have to close district-wide if that's what the health department advises. And this, I think when we went over it last time in terms of like kind of black and white or yellow, orange, and red, like minimal, moderate, and substantial, we're like, it has to be this way, like we have to close all the schools. We have learned more from the county since then that it doesn't have to be quite exact, that we can make kind of a case-by-case basis.
It doesn't have to be all or nothing.
Yeah. Oh, it's not going. Sorry. There we
And
go. And then this goes over that even in minimal, if there is a severe outbreak in one school or one grade, that would overrule any of the metrics for the county's transmission. Also, that we would make a decision. There's very little and varying guidance on how many days you would need to close. So we'd really have to hammer that down with public health officials as far as like deep cleaning, how long to stay out of the buildings if we needed to. So just know that that's out there and that we'll get advice from someone who knows more than us about how long to stay shut, how deep to clean, etc. And then this just goes over the reality that until we have a vaccine or there aren't any new cases, that we may have to do this several times. So just be prepared. And then the goal would be to minimize interruptions as little as possible and to be in person as often as possible. And then this document is on IDPH's site and also referenced in the DuPage County metric too. This goes over, we went over this last time, minimal, moderate, and substantial. I guess the thing to point out this time that we're kind of learning about when we presented the first time is the word encourage is in each one of these. So it's not, again, not black or white. You know, encourage, use your discretion and expertise as, you know, people who know schools, and you know, we'll talk to the health department should we really find that transmission is substantial. And then this goes over 9/27 through 10/3, which is week 40. So we were in blue, which is stable COVID metrics. These are the IDPH metrics that inform that color on the map. So The only one that is at warning is the new cases per 100,000. This is the one that I've been tracking day by day, and it's really hard to track. I'm just going to put that out there. I pull from the daily press release from the DuPage County, and I think we will be over 100 cases per 100,000 this week. So, and then the positivity is going to go up from 4.5% as well. So,
And you're basing that on the daily reports?
yeah, I've been pulling it out from there. I'm also looking on IVPH. The sad thing is that they don't always match. It's very hard to track, but I have for the last couple weeks. So for this week, I hand tracked it myself before the metrics came out, and I was off by 2 on the cases per 100,000. So I think we're going to be really close to that.
And just to remind people that
Yeah.
we're 10 days behind. So these
Yes.
numbers, while they came out last Friday, only go up until October 3rd. So
Yeah.
what Katie's doing is tracking.
I'm
The
trying to
10-day
get ahead
gap.
of it because
Mhm,
the kids are
mhm.
coming back this week. So
So IDPH
Yeah.
will officially announce last week's numbers on Friday.
Right.
So we'll get that official count of cases per 100,000 this Friday.
And that'll be for last week.
That'll be for last. week.
exactly.
And this week,
It's
you
really
think we're
hard.
going to be over the 100?
Well, that would be for week 41, which
Oh, okay.
is
It'll be the-
10/4 to
this Friday.
10/10.
Okay.
Yeah, so it's the week that ended on this past Saturday. The youth cases have been decreasing the last 3 weeks. So that's been a good trend. We've been above, for new cases per 100,000, we've been above 50, which puts us in moderate since the middle of July. And our test positivity has been good. We've been doing, one of the things that really informs that is the number of tests done. And the number of tests done last week was over, for this week, was over 21,000. So it's quite a few tests. So that is keeping our percentages down. This is a little bit more recent. This is from the Northwestern site where they pull data from IDPH, and I can put in the 5 zip codes of the towns where our schools come from. And you can see, so this is more recent. This isn't week 41. You can see the trend that's happening there. If you look at the bottom on the cases per 100,000, we're going from 77.4. And then if you look up to the top, we're up to 121. So I don't like how that looks. But again, our percent positivity is staying around 5 locally. So just thought that was important to get a little more recent local data there. And then every week we have been reporting in the district digest. So it'll have kind of a state of the metrics that you can click on. And then we're trying to provide the D41 community with our return to school status, community transmission, kind of the things that have stood out, and just those health reminders to keep that will keep us in school. So wear a mask, watch your distance, wash your hands, and stay home if you've been around anyone with COVID or you yourself have symptoms. And these are the trends to watch. The deaths have been a little bit on the rise, and we're going to see for this week that we're following week 40 here, there were 6 deaths. We're going to go up to around 14 deaths for this week. And then this, again, just gives a different visual of the cases per 100,000 historically. And then the test positivity. And like I said, you'll see the last 3 weeks we've been under 5%. We've been doing really a ton of testing. And then this is the rolling average by age group. And really the age group that's on the rise is those 20-year-olds. But it gives you perspective. The kids were up when we started talking about this in August, and they've moved their way back down. So really the kind of 20 to 59-year-olds are the group that's on the rise there. And that's it. Do you have any questions?
Katie, you were expecting positivity rate to go up too.
I spent the afternoon looking at all those numbers again. The so frustrating thing is that the IDPH and DuPage County numbers do not match. My husband was like, you need to just call the county and ask them where they're getting the numbers for those daily press releases. Because I did get super, like I said, I was off by 2 for the report that came out on Friday. So maybe I will call them and see if they can give me information. I'm pretty confident. It is the weirdest, like watching both IDPH and
Yeah.
DuPage County, because they don't match exactly. It ends up working out like when they both post, because they each post their own metrics, that it ends up they post the same numbers, but I don't know where they don't exactly match. I don't know how else to explain that. Yes, yes. So it's hard to anything except for deaths and the actual cases. And then I know what the county population is, so my calculator has been working a lot. So,
I appreciate it.
but yeah, so anyway, it just, I just want to like get ahead of it because I really, want us to be successful and be realistic about what is going on in the community. So.
And I think the reality of the numbers that are going to be coming out and looking at this by age group, we have not been in school yet. And so, as Katie said, the youth cases have been dropping over the last 3 weeks. And so really the messaging to families is that all of your actions make a difference. It's not just kids and making sure that your kids are wearing masks when they're playing sports or when they're on the playground, but it's all of the actions that we take as a community that is going to drive whether we're back in school or we have to go remote. So just keeping that in the forefront of people's minds as they make daily decisions about what they're doing.
So to follow up on that, so we're looking to bring our first kids back on Thursday.
Yes.
So could you just kind of articulate what those steps that families should be taking? I know that we've all heard them a bunch of times, but I think it's important, given that we have kids coming back to our villages this couple of weeks, just that's out there again from our Pratt team.
Yeah, I defer to you. I think the number one thing is wear a mask, right? That's like our biggest protection. So making sure that you're wearing a mask wherever you are. And I think now that, we're looking at increased numbers in our community, not only our community, I think if you watch the national news, the numbers are going up everywhere, but just to emphasize that that's like the best protection that we can have right now, and washing your hands and, continue to social distance and stay away from large crowds. What else?
Katie and Ellen, I want to bring in, we've got 2 board members who are joining us remotely.
Okay.
It'd be kind of hard for them to jump in. So I want to just sort of call on some folks and see if they have some questions or comments for you. So let me turn to Guillermo. Do you have any questions or comments for either Ellen or Katie?
Yeah, just a quick question, Katie. I don't know if you have this answer, but going back to the adaptive pause, do you know, or can you elaborate a bit further into what would trigger that to happen? Is it a combination of factors or one particular factor? Do you know that?
Yeah, it's Guillermo, it's a variety of factors. So if we had 2 cases in a classroom, the county would consider that an outbreak. And so they would guide us in terms of whether it's that we need to shut that classroom down and do deep cleaning, or whether we need to look bigger and possibly close the school, depending on whose guidelines you look at. CDC says 2 to 5 days, but we would work through the DuPage County Health Department. So there's different reasons that you would take an adaptive pause, anywhere from, the transmission rate in the community and whether it's deemed safe to be in person for school, or a shorter duration if we had to do something with a specific classroom or a specific building in the district.
Thanks.
Yeah, and then if you go back to the DuPage County metric, it gives you exact numbers. So cases over over 100 per 100,000 will put us into substantial.
Mhm.
Positivity over 8% will put us into substantial. 2 weeks of being youth cases increasing by 20% will put us in substantial. And I think 2 weeks of greater than 20% increase of new cases will put us in substantial.
Right. As will our surrounding counties, if any of them are in orange based on the IDPH regional color coding system or
Right.
something else.
I put it in all the slides. I just didn't go over it in detail tonight because I didn't want to bore you to death. But if you have any questions about it, I'm happy to answer. I obviously have all the numbers memorized. So, but-
Well, we may give you a chance to figure out one at a time.
And I think the important thing to know, and maybe Dr. Phillip could comment on this, if we've got new cases approaching or at 100 per 100,000 and a positivity rate that's inching its way, closer to 6 or even above, that's a dangerous level of community transmission. So, we want our community to be well aware of this. I think the significance of quarantines has now started to hit families. Now that we have a shift date, we're hearing from families almost daily about positive cases within their family. And so I think, what we've been talking about for the last several weeks of how significant quarantines and isolation can be on families, that is now starting to hit home. People are realizing, there is no wiggle room, and 14 days is a long time. So the reality of that is starting to sink in.
Thank you, Melissa. Guillermo, did you have another question before I?
I just say thank you. Thanks, Bob.
Thank you. Okay. Bruce, any questions for Katie and Ellen?
More, I guess, for Melissa, maybe. So when we go back, what should I tell parents that the chances of the kids going back to full remote would be there is probable, unlikely, a 50% chance, a 25% chance, a 75% chance?
Right. I think, Bruce, it's what we've been saying to people all along is they really need to be aware of the county data and do what they can and make decisions as a family about their own behaviors and choices that will help to bring that county transmission level down. There is nothing. We will open this week on Thursday. And if we are moved into red, when we have our update on Friday, we'll monitor it for another week, but we'll keep our family informed. And so if the county moves the designation into red this Friday, there'll be, a great deal of conversation around it. And I have no doubt all the way through next week until we get closer to that next update. So we'll be communicating with families too. And, we'll take our guidance from them. So, as we've said, it really hasn't changed other than, at this point, it's not the district that's going to decide whether we open and stay open. It really is the community and their choices that will determine whether we can stay open. I mean, we know we'll open for K through 2 and pre-K, and then we're going to have to monitor closely what happens between our November dates to start everybody else back. So, I think the message is it's really in the hands of the community at this point. It's not in the hands of District 41.
And that's for not just us, but that's for all districts throughout DuPage County, pretty much.
Yes,
I mean,
everybody.
like if we all go back, we get red, we all have to go back, or sorry, not keep attending school. Or so in 200, I know they've gone to they're in school quite a bit. Would they have the same choice? They would have to go back to full remote, or could they do their social distance of 6 feet and be okay with that?
Right. We would, every district would have the ability to make their own decision. The health department will give guidance, and then every district will have to weigh that guidance and decide if there's information that makes us feel, if it's strongly worded guidance about the level of community transmission, that's information that I would bring back and share with all of you. And every district then would have to make their own decision from there. The health department, is will give guidance, so we'll see what their guidance sounds like this Friday and bring that information back to people.
Okay, great. Thank you.
Thank you. Thank you, Bruce. Let me turn to the table here again. Ted, any questions, comments for Katie and Ellen?
No questions.
Thank you very much. Jessica?
You said we're doing a lot of testing. Like, what do you attribute that to? And I don't know, what are your thoughts about where we're at with the level of testing relative to kind of what has been maybe suggested by the thought leaders in this space about what's an optimal level of testing?
I'm gonna let the doctor answer that one.
That's fine.
But I mean, in the spring, we were only testing sick people.
Right.
We were only testing sick people. Now we are surveilling. There are school districts that are back in school. Their children are getting sent home. They're getting tested. That has probably brought our youth numbers down. Elmhurst District 205 has a COVID dashboard that I stalk because I do. And they've been in school for a few weeks. They have over 1,000. They're a unit district, so they have high school also. They have over 1,000 staff and students on quarantine. And then they also list their positive cases. Their positivity isn't extremely high, but 1,000 staff and students is a big deal. So that's like when Bruce asked about what is gonna, how can we stay open? If we happen to have a lot of staff that get sick, that's a decision that we have to make. We don't have the same space as other school districts. That's all written in that adaptive pause. That, what your next door neighbors are doing might not be what we can do because we don't, our kindergartens are in the gym now. It is going to be a case by case what your human resources situation is and, space issues. So, yeah.
Yeah. And
It's a lot.
in our board packet was a PDF that was included, a national decision about point effective testing. It was about testing, but one of the things that struck me about it is that based on our number per 100,000 people, that metric, it's saying that in that range, with a group size of 25, there's a 46% chance that at least one infected individual is in that group, which I think is just where we are at now in the moderate level.
Yeah.
And of course, that goes up as
Right.
as that number goes up, the number of cases per 100,000 people. So I just think that, we need all hands on deck to be following all the
Right.
protocols so that we bring all
Yes.
these numbers down.
Because, people aren't doing it on
Purpose, yeah,
There's
right.
like 30 to 60% of cases are asymptomatic or pre-symptomatic. So,
Right.
so that's why we really have to stay apart from each other, which is really hard. But we just have to follow all the rules and you have to protect the people that need to be protected. Making a choice to go to school might not mean hugging grandma and grandpa on the weekend anymore. It is going to take all of us to make this successful.
Well, thank you for all of your efforts and crunching all the numbers and
Thank you, Jessica.
Thank you.
Brother Jason, any other questions or comments?
No, I don't think I have any questions. I appreciate all the numbers. And I think I just double back to Jessica and just say, this is really going to be a community effort just to keep our schools open and to keep all our kids safe. And it's everyone's responsibility in this community just to follow those protocols of wearing a mask, washing our hands, keeping our social distance, and making sure we're just taking the measures to keep everyone safe, including if you're sick, stay home, keep your kids home from school. That's what it's going to take for us to stay open.
Yeah, and if you're not sure, call the school nurses, call your doctor. It is a lot to wrap your head around. Just last night, I took care not of a junior high teacher from Hadley, but from a different school district who brought her child in for COVID symptoms, and she's like, "Can I go teach tomorrow? I'm like, no, you cannot. Your child has a
Mhm.
pending COVID test. Like, until you get it back, you're on quarantine, you know, so.
That's the thing. I mean, I think it's.
And then everyone at home has to
Right.
stay home too. It's a lot to wrap your mind around. I know the school nurses have gotten questions like, mom tested positive, one sister tested positive, the other two are negative. Can I send the 2 negatives to school? No, we can't. So it's a lot, and it's sneaky because it's kind of an invisible disease, and you know, we're tired of it. This is week 42, you know? So everybody's tired. The weather's getting terrible. We're all going to be inside. Like, it's a lot. We're going to have to be really diligent to make this successful.
But I mean, I think the numbers show that like time is of the essence to really embrace what needs to be done as far as the preventative measures that we can take. So, I mean, I remember a long time ago, something that stuck with me that you always said, Katie, was that you should treat everybody like they're COVID positive. So you should be wearing a mask in front of everybody. You should be keeping your distance in front of everybody. You should be constantly washing your hands. And same thing, you know, within the schools, that like you kind of have to make the assumption that everybody could be COVID positive, and how would you deal with somebody that's COVID positive? So just keeping that forefront in your head. And
Okay, thank you. So Katie, Ellen, you've definitely laid out that there is a increased rate of community spread per the metric of 100,000. It's moving in a bad direction. The rate of increase that you've seen recently compared to previous reporting periods, does that rate seem accelerated, or is it just a slow chugging towards that 100,000 plus? You seem to think we'll definitely get there, but I'm just curious whether that rate has changed, or has it just been a steady sort of incremental movement towards it?
Well, you can see like we were really low in July, and then that's when we crossed. You can see on that one graph, and then it went way up, and then we've been kind of sawtoothing back and forth since July, basically. So yes, they are heading in the wrong direction. Yes, we are doing more testing, which will make your numbers go up. I had shown Dr. Kaskowski, like if you look at Champaign County when they were including the U of I numbers, so you'll get they did 60,000 tests a week, and you'll get like 1.5% positivity. So you can shove the positivity down like that, but their cases per 100,000 were like 150. So that's why it's not like this black or white, like we're insubstantial. Well, we have to look at why we're insubstantial. So right now, the schools have nothing to do with it. We haven't been in school. So, you know, except for St. Pat's, I guess they've been in school, but you know, so we have nothing to do with it, what's coming out on Friday. And that's really hard because all the data is old. So that's why I was trying to pull it myself, just so we could get ahead of it, and just, you know, so everybody knows what the reality of our situation is in our community transmission. So, yeah.
Okay.
I think
hope that makes sense.
Is this the highest cases per 100,000 that we've hit though? 110, if you're looking at like the.
Well, it depends what the final number
I mean, I know.
will be on Friday, but yes, I think that our highest, well, I don't know what it was in the spring.
Okay.
I was not.
But it's certainly going to be the highest.
I was working and taking care of
Yeah.
COVID patients,
Yeah,
and
yeah.
so I
You weren't
wasn't
counting
following.
I think the reality.
Yeah, the
is
numbers,
we
so-
weren't testing. as
So I've
much as
only
we
been
are.
following since I started helping in August.
Okay.
So
That's
sorry.
Well,
That's where my knowledge ends.
I do want to just join all of my board colleagues, superintendent, and both of you in really asking the community to partner with us, that this board and this school district is going to work extensively to keep schools open and kids in class, and we'll advance that effort with a conversation with Dr. Phillip here tonight. But it is really going to require prioritizing the schools, and all the national data, all of the commentary, all of the research has made it very clear that if communities have to prioritize schools, and that means it's a bit of a trade-off. You can't do everything, and it's difficult, and we're all working under the burden of these restrictions. But it may be possible to salvage schools. It may be possible to do schools while we can't do other things, and that's going to mean staying out of those social settings, right? It's going to require just giving up other activities. I know in some communication with community members, the sense was, geez, without the school, the kids need whatever they can get from the extended community. So that might make you just a bit more risky in your interaction. But if we can put the kids in schools, it will take the place of a lot of that other activity. And I hope that that's true. I mean, that's a bet that I'd like to make and win, that if we do everything we can to keep kids in school, the community is going to work really hard to keep that infectious rate from getting too high and then to pull it back down. I believe that's what they want also. So I thank both of you for all the great work. We'll be looking to see what you come up with over the next week and beyond. But thank you for coming out with us tonight.
Yeah.
Means a great deal.
Thank you.
Thank you. All righty.
And I apologize, when I was speaking, I didn't have my mic on earlier, so.
Oh.
No, I had the mic.
No, your mic should be on.
My
Your mic
mic
is
was
on.
on. I didn't unmute. That's what it was. So I apologize for that.
Oh,
I didn't
are we
think you could
supposed to
mute.
unmute?
Oh, no, you don't have to unmute. You're good.
No, you're good, Jay. You don't
Oh,
have to
I
do a
am?
thing. Yeah, you're good.
Oh, well, good.
You're not in control of that, which is a good thing.
That's good.
Okay.
Hands off.
So, well, now we get the pleasure to introduce Dr. Matthew Phillip. Dr. Phillip's board certified in internal medicine, serves as the treasurer of DuPage Medical Group. Dr. Phillip is also the chief innovation officer for the organization, where he focuses on integrating clinical innovations into DMG's existing programs. Dr. Phillip has earned his medical degree from Northwestern University Feinberg School of Medicine and completed his residency in internal meds at University of Illinois, Chicago. Dr. Phillip is heading up the DuPage Medical Group COVID-19 Rapid Saliva Testing Program, which is why he's here tonight. So please, if there's anything that we've talked about in the metrics, that we didn't quite get right, or maybe didn't sound the alarms great enough, this is your specialty area too. So if not, I'm going to turn it over to you.
Yeah, absolutely. I think, first of all, it's an incredible privilege to be here with you guys. I know that one of the things that we've been thinking about over the last several months since the pandemic started, we started meeting about this in January, creating a strategy to ensure our patients, our practitioners were okay. And then we expanded from there to work with a variety of employers, and we've been consulting for over 100 businesses, and we've learned a lot over the months to come. And a couple of months ago, as just personally, our children were going back to school, we said, well, hey, maybe we can reach out to schools and see if we can take what we've learned and how we've been successful to bring it to our school systems and be a benefit to our community. And then we invested in increasing our testing capacity and some strategies. And then out of the blue, Mr. Bruno called me on my cell phone, and he asked about testing opportunities. And I kind of looked at it as providential in a way that we were creating this capability and looking to expand. And then he reached out right at that time. So I think it's really, fortuitous timing. And so I'm excited to talk to you about what we can potentially do. I think a couple of things I would say is, I think you have an opportunity here. Einstein said that in every crisis, there's an opportunity. And I think the steps you're taking, I think, are very admirable. I want to say, you guys, I think you're doing a great job here in terms of how you're thinking about things, maximizing, obviously, staff and student safety is number one, but also providing reassurance to the community and expecting the cases are going to happen. There are going to be people who have positive cases in the school. And how do we prepare for that? How do we create a structure now that helps us deal with that without panicking, but saying that, we've planned for this and here's our strategy and here's what we're going to do to make sure that this doesn't grow from there. Now, some of the things that happen with COVID, or SARS-CoV-2, the virus they call COVID-19, is that it grows in clusters. So it's a little different than influenza. Whereas influenza, it's, one person gives it to one person and one person gives it to another person. This tends to grow more exponentially in certain areas. And what we find is that about 70% of people actually never transmit it to anyone else. So the Pareto principle in terms of the 80-20 rule actually is very applicable. 20% of people lead to 80% or so of all infections. And so creating a strategy for those super spreaders and how understanding how that works is critically important. We've seen that with the NFL recently with some teams, that had protocols in place, that had testing in place, but then, cut some corners and then it spread wildly. We saw that unfortunately in the White House, where one case went to over 20 or so cases, and that we can't depend too much on one strategy, but it really needs to be a layered approach, and that's the most effective. The good news is that we have learned a lot from efforts all around the world, and we've tried to take the best practices from those efforts and incorporate them in a strategy that's been effective. In DuPage Medical Group, we've seen that healthcare providers tend to have 2 to 4 times the rate of getting COVID-19 as the general population, but our rates have been under or lower than the community, and that this spread has been increasing in terms of using the most effective prevention techniques. Now, the things that are working in your favor are that recent research shows that, I'm not a pediatrician, but from the Journal of American Medical Association in Pediatrics, show that children under the age of 18 have about 44% less risk of getting COVID. They also, another article earlier in September showed that their rates of hospitalization when getting COVID are similar to the flu, influenza, which is great. And there's indications that they probably transmitted less also, which are encouraging things. And as that science catches up, I think you're going to have data on your side as you look to safely open, but then you're going to have other things. And what we're looking to provide, if you want, is a testing strategy. Now, the reason why we partnered with Yale University in terms of getting Saliva Direct was because of our partnership with NBA. We were working with them on their bubble program, and they invested early with the Yale Saliva Direct program, and they connected us with their program. And of course, the NBA was very successful with their testing strategy. Of course, they had a bubble, but as they incorporated testing, part of a wider protocol, they found that it was very effective. And we invested in the program to scale it. What we noticed is other healthcare systems kind of pulling back from doing community testing to kind of allow public health organizations to do testing. We thought that may not be the best approach, that we're looking to really lean in because there are a lot of gaps that have been created. And if we can fill those gaps, I think we can really maximize safety. Part of the sense of urgency is that we are going to really a second or third wave, depending on how you look at it. I look at it as a third wave because there's March and April was that first wave. The CDC estimates we were only catching 1 in 15 cases at the time. That's why the absolute number of cases was low because of lack of testing. The second wave, really in July to August, thinking nationally, we did see a bump in the Chicagoland area as well. But we were capturing about 1 in 5 cases, again, CDC estimates. And I think now we're in the beginning of the third wave. And so I think your data is accurate in the sense of there's increasing transmission that's going to happen. We are seeing a little bit less transmission than potentially, the data that you had, but we know that those numbers are going to rise. And how do we prepare for that? The reasons for that are 3 main things. One is human psychology. I think as was already heard, people are over it. They want this to be done. And that's not true just of now. That's historically all pandemics work this way. And that's usually why there's a huge next wave in this time of the year. Other is human behavior. People are enclosed indoors, it's colder. So there's recirculating air. This is part of the reason for the second wave was because in the Sun Belt, there was enclosed areas with air conditioning leading to that spread. And then now this third wave, because it's going to be colder, it's heating and things like that area, and also a lot of the holidays. We've seen a lot of spread around holidays. So as we think about Halloween and then Thanksgiving and then Christmas and Hanukkah and New Year's, we really need a strategy of how do we deal with that, but we know that the spread is going to increase during those times. And then finally, the behavior of this virus. It increases in drier, cooler climates, kind of like influenza. Although it works, the transmission is obviously much higher. And so it transmits better, and then the transmission is higher. And that leads us to this spot. I think the best way of thinking about this is in terms of long-term thinking. I think because of our fatigue, we always want it to just be over. Maybe just we're going to get a vaccine and then it's just going to be done. And then the FDA delays vaccines by 2 months for the review process. I personally disagree with that decision because I think right as we're going into this wave, not having that tool is just tying our hand behind our back. The FDA did include, so that same vaccine that was leading, with just Pfizer, they increased the ages that could be tested on to 16 and 17-year-olds. And then just yesterday to 12 and 15-year-olds. So the reason why vaccines generally don't test pediatric patients is because of safety concerns. So if adults have side effects, children have much more exaggerated side effects because their immune system is much more responsive. And so the fact that they're expanding that speaks a lot to their safety, that they feel that it's potentially safe. But the emergency use authorization, which maybe is on target for the end of the year, is unlikely to include pediatric patients, especially in the beginning.
Right.
So the way that vaccines tend to work is adults first, and then once that's proven to be safe, then pediatrics next. And so you're really looking at next school year to have a widely available vaccine for your pediatric patients or, pupils. And then also potentially, really second quarter of next year before it could be widely available for teachers, maybe even early third quarter. And that's for a variety of reasons. And so a strategy that thinks outside of vaccines is going to be important for you guys. So when we looked at what strategies have been effective worldwide, one of the things that has been effective is a testing strategy. And so the model that we looked at was Germany, is that after their first wave, they were really a model of how to deal with that first wave. They had a strict lockdown, masks, mandates, and then they instituted testing. So their cases were about 100 per million at that time, which is right around where they are right now, actually. And there was a lot of concerns, the similar concerns that we had, because remember their first wave was before ours, was about how are the students going to be okay and how the staff going to be okay. They went with twice a week testing with PCRs. And then they found that they were able to dramatically decrease outbreaks. They were able to maximize safety and keep in-person learning. Of course, you know better than I that in-person learning is critical for early childhood education. There's just only so much you can get, remotely. And so the fact that they were able to maintain in-person learning, I think was a huge lesson for all of us. Those efforts have been replicated across the world. And in Australia, for instance, France has also done similar things. And then locally, we've also seen that happen in some of our colleges. Urbana-Champaign, University of Illinois, Chicago, have also incorporated twice weekly testing. Yale University, of course, has been doing that as well. And we can compare how they've done versus universities, excuse me, that haven't had testing. There's been about a 90% decrease in infectivity rate in terms of colleges. That may speak to a variety of different factors. I think schools that are focused on testing are probably already also taking other prevention seriously, but it's hard to ignore the data. And so one of the possibilities would be to roll out a testing strategy, especially as we know that cases are going to rise. This is really only the beginning. The cases are going to be nationally higher than the first and second wave, a function of more testing and better transmission and things that are there. Thankfully, the mortality rates have decreased because of better treatments that are available. And so, but we don't know what the long-term morbidity would be, especially for children. And one of the blessings in disguise is that, unlike other pandemics, children have actually been relatively unscathed through this, and we're hoping that continues. But still, I think for everyone's benefit, I think it's best to be extra careful. So that's what we're talking about now. In terms of, excuse me, I lost my voice a little bit, so that cough is a dry throat. I've been
For the explanation.
I'm negative just in case it's laryngitis, chronic laryngitis. So I can see everyone getting a little nervous. Excuse me. So that's what we're thinking now. In terms of testing, there is going to be wider availability of testing over time, and as that cheaper test is available, I think this could be something where we can ride down those cost curves together. We don't look at this as some amazing business opportunity or something like that. We're really looking to be a blessing to our communities, the patients we serve, and their friends and families and things of that nature. And if we can't do that during a pandemic, then are we who we say we are, kind of thing. So that's kind of the mission mindset that we're coming at this with. And so as they're cheaper and cheaper tests, of course we would pass that along to you as well. And then I'll open it up to questions.
Well, let me thank you, Dr. Phillip. And let me just open it up to board for questions and comments. And I don't know if there's any bottled water somewhere in the room where maybe Dr. Phillip could step away and grab a little bit of water while Ms. Moak goes and hunted that. So let me turn to the board and engage them in conversation here. Ted, any questions or comments for Dr. Phillip?
I guess I'm interested in more of the specifics in terms of how much testing is needed. In reference to that the paper that Dr. K put in that's attached to the meeting, it appears that there's numerous factors that go into that. Some of it has to do with the infection rate in the community. I can't remember all the different things. It was the sensitivity and specificity of the tests and all that kind of stuff. Could you touch on that a little bit?
Yeah, so we've always striven to get the best quality tests available. So the Saliva Direct is a PCR-based testing. That's significant because PCR is in the kind of mid 90% range. It's for sensitivity and high 90% range for specificity. It's the gold standard of testing. The test that we would do is a saliva-based test. So it really minimizes student discomfort because any child can spit into a cup, but having a nose and a swab in their nose can be uncomfortable, and we don't want to give them a negative reaction to testing.
Right.
So high accuracy and high comfort levels too. They've also been validated. The NBA actually did a study comparing Saliva Direct to nasal PCR and found comparable rates of detection at 97% comparability. So you can essentially get the accuracy of a PCR for a fraction of the cost. So a PCR test would be about $150, nasal PCR. Saliva Direct is about $35. So a fraction of the test for similar accuracy and ease of use.
Dr. Phillip, if I could maybe just redirect that. I think, Ted, also part of your question was about maybe how often testing would occur. And I know we've talked a bit about, given this age group and the value of testing once a week. But can you address that question?
Yeah, so any additional testing is going to be a help. So, you can always start it once a week. Just what Germany and did for their school system was twice a week testing. The reason for that was because of the latency period of an infection. And so if someone is infected, the earliest they could be infectious is about 3 to 5 days. And so they were just trying to catch both of those periods of time. So that's how they constructed that. But understanding the decreased risk to children, you may come up with something differently.
Okay. So it's not like a hard and fast rule.
Unfortunately not. No, we're basically seeing different schools, different countries, cities, schools, employers, all doing different things. And based on contact tracing studies and research studies, we're kind of seeing what the best outcomes have been so far.
Okay. All right. Yeah, that's part of my confusion. You mentioned U of I, and they're testing twice a week or something. And my son goes to Purdue, and they randomly test 10%.
Right.
Pick a name out of a hat.
No, that's exactly what's happening. University of Wisconsin also has a certain kind of test, but they were kind of doing different random testing. Then they had a large outbreak, and then they increased their testing and did a few different things. And so it's kind of where do you want to err on the side, and then create a strategy from there.
So you have some dials that you kind of guide with based on whatever's happening.
Yeah, and the beauty of it is that if you're seeing community transmission increasing, you can increase frequency of testing. When you see it decreasing, you can decrease frequency. And so it's not like one standard. It would be tailored to the situation.
Right.
Higher risk, higher protocols. Lower risk, lower protocols.
Okay. All right. Thank you.
Yeah.
Thank you, Ted.
Can I just piggyback on that?
Jay, please.
A question that I had is that obviously you inside a school community, you also have a subcommunity of kids with medical issues, medical histories. And then you have staff members that come in contact with that cohort of children. Would it make sense to have a different testing protocol for that type of a subgroup, or different protection measure be in place for that sort of subgroup? Or is it more like, this is universal across the board, this is how things should be done?
Yeah, we try not to differentiate because kids pick up on those kinds of things. And so we just try to keep a standard. And so when we look at the studies around the world, they've just kept a standard safety. And because the risk of getting it are the same. And so, I think that's what you're trying to avoid is the spread. And so because it spreads in clusters, if you can identify those cases early, that's how you prevent from going to, having to shut down a classroom or a school and things of that nature. And because of a lot of the gray area that are there in terms of what I saw from the county recommendations, I think if you have testing, it could really be something that justifies staying open.
Right.
Because you can basically say we have the safest protocol of any district. And so you could really lead the charge on that and trailblaze.
So if we implement a testing protocol and there's just increased testing obviously identifies more unknown positive cases.
Mhm.
So given that, does that change your numbers looking at to stay open or for an infection rate? Because if you're not doing any testing, is two positive cases is considered an outbreak. If you're testing, you might identify those two, and so you're able to have those two in isolation. Does that change how you deal with those metrics or no?
Yeah. So the way I would think about it is it's actually the asymptomatic person is really the one who gets you, or the pre-symptomatic person.
Mm-hmm.
That's why 20% leads to 80% of infections. For instance, there was probably a famous kind of outbreak in Washington State where it was a choir practice and they were socially distanced in a big room and everything. One person was asymptomatic, but had it and gave it to 80+% of the other choir practice, right? And several people died, unfortunately. And so it's like they didn't know they had it, but what you don't know can hurt you. And so identifying those people early and then showing that you can identify them and quarantine them, again, gives you just an incredible ability to snuff out those outbreaks really quickly.
And then from a pricing perspective, and in looking at it from a business perspective, a lot of times, your business model pricing is based on the fact that you have to keep people working, you have to keep machines running. So in looking at that, if you know that there's a certain volume coming in from some places, that testing rate go down, or does it stay the same on a per test basis?
Yeah, I think the way we're looking at it, so we don't, we had to kind of ramp up this.
Mm-hmm.
So we obviously bought the several $100,000 equipment and all those kinds of things. And then we would hire staff in order to do this. But I don't think we look at this as a long-term thing. I think we're really looking at this as maybe a 1 or 2 month partnership with Saliva Direct.
Right.
And then once there's a point of care testing that's widely available, it'll be a much cheaper, lower staff, lower overhead way of.
So you're looking at basically you hire as needed and you're running tests as.
Yeah, exactly.
That's what
I think we would look at, because
that makes sense.
because we don't want to hire people and then fire them,
Right.
or have that overhead. Is like we're just trying to adjust to what, like we're trying to be as adaptable as you guys,
Right.
Because things are changing. But a lot of this is predictable, and so I think sometimes there can be this fog of where we think that we can't know what's going to happen. But at least for the last 7 months, we've been accurately predicting what was going to happen and providing consulting services on that. And so we have a pretty good idea of what we think is coming next, and let's prepare for that. And I think that's always a good strategy.
That's really coincidental. When you said there's a fog, my glasses, I just smiled. My glasses fogged up. It's kind of fun.
The struggle is real.
Yeah, it is. It is.
Thank you.
I'm good. Thank you very much.
Sure.
All right, let me turn to our board colleagues who are virtual. Bruce, questions for Dr. Phillip?
Yeah, so you said each test would be about $35. And we would be testing about 3,700 tests a week. Is that right?
I think it's around 3,500.
3,500?
If you included all students and weren't counting students who were.
Plus
who
staff.
opted- Yeah, this is only be for students who would opt to come back to school. Students who had decided to go remote would not be under any requirement to be tested. So, but let's just go with the 3,500 total.
And we think we would test for how many weeks to make it effective, or so we would know?
Yeah, we don't really know. I think there are two factors that you're saying is that you can test however long you want to test. So I don't think, I'm not saying that you have to test for the whole school year or anything like that, but, we do know that it transmits higher in kind of the winter months. But, if cases are rapidly going down, you may say, okay, let's take a pause on testing. The other variable is we do know that several companies are doing point of care testing. And so there's Abbott, famously has the point of care test. 150 million of those tests were bought up by the government, and so that's not accessible. But we would imagine, and we have intel, that several other companies are working on their own point of care testing. And so maybe that'll happen in 6-8 weeks or something of that nature, where it could be accessible. And so that's why we're talking about maybe a preliminary saliva direct testing, and then as point of care testing gets cheaper, then we'd flip it to that. So, and if you could buy it on your own, just buy it on your own. Like you don't have to work through us. It's just, again, we're trying to just be a help here, is that right now we don't see a way of getting testing aside from a medical group. And then of course, if people were positive, we have the nasal PCRs and treatments and physicians and things like that. So it's kind of a full service operation in your neighborhood.
Do you know how long Germany has been testing? Like, have they continued to test once a week for 8 weeks or 6 weeks?
I believe they have,
20
but I'm not 100% sure, but I believe they have, yes. I mean, they are now, I mean, their cases have been rising rapidly. So I don't know if there was a pause there, but at least.
Yeah, I'm not, from things that I've read, I'm not aware that
I think
paused
they've
that.
been continuously
They've really
testing.
committed to testing.
Yeah.
I'm sorry.
They committed to testing. They continue to test. I think they've been doing that from the near beginning of their outbreak. I'm not aware of any kind of pause to testing.
And they do have one of the lowest rates in the whole European Union.
So if we tested for, I estimate about 125,000 a week. Let's say we did it for 8 weeks, that's $1 million. Okay, I'm just trying to get a feel for how this would impact the budget.
Yeah,
because it's something to consider.
Yeah, obviously, what kind of contractual arrangements, if we were to decide to go forward, we would be discussing with DuPage Medical and taking a good look at what that costing would be and how we could impact that cost curve. So that's something we would look to do next if we continue to be in conversation with you. But those are relevant, all, of course, very relevant questions.
Absolutely.
Do you remember how, I remember we kind of talked about it enclosed a little bit. We talked about it being about $2 million to the budget. Do you remember how we came up with that number? We were estimating it's going to be about $20 a test, I believe.
So, Dr. Phillip, there is the widely recognized and frequently now utilized testing that the University of Illinois has done through Shield, Illinois. And I think their pricing per test was roughly $20 based on their, it's really based on what their costs are and then what they think they can deliver this for. So your price point is a bit higher. I think your point was that you had to capitalize your labs. You had to spend $200,000-$300,000 on equipment in order to bring a lab up and then bring staffing up. Where I think in the University of Illinois situation, that was not a cost that they anticipated labs bearing, so that the lab's direct cost to just run the test and probably some staffing would be considered, which would mean the price is far lower. So I think that's in part what the difference is, Bruce.
Yeah, they developed their own test for their machines that they already had in-house. And so we had to buy specific machines in order to incorporate the tests that were created externally. Yeah, but again, I mean, I think you should go with whoever, can provide. So if you can get it for $20 a test, then do that. That's no small savings.
Yeah. I will note for the record, at the moment, the Shield, Illinois protocol is not available to K through 12 schools. There are a number of regulatory issues that they still have to comply with and meet. So at least for the foreseeable future, that's not an option that's available to K through 12 schools. One would hope that it would be long-term, and if it were to develop sooner, that would be certainly a blessing to everybody in the state. But at the moment, unfortunately, it's not, which is why the fact that Yale University, which really earned the emergency use authorization, which you are now partnering with, and I want to talk to you more about that, is really a terrific opportunity, given that the U of I's testing is not accessible to us.
Yeah.
Yeah.
Yeah, I mean, my worry is that this would jeopardize our early childhood center, but that's just we
Yeah.
can talk about that more.
Yeah.
It's just-
And-
Those are internal discussions for us, for sure.
Yeah.
Let me,
That's it.
yeah, well, thank you, Bruce. Good commentary.
Oh.
Let me then turn back to the board. Jessica,
Sure.
questions for Dr. Phillip?
Yeah. So for anyone following along, the PDF that was in the board packet on page 14, there's a chart that says the model of testing strategies. And Ted, you kind of referred to this a little bit. So in looking at that chart, the mother in me says, I want to be doing this test every 1 to 3 days, because that tells me that I'm going to get 80 to 90% infection transmission reduction. So, if I'm going to send my babies to a building, then I want the gold standard of the number of the days. If I'm a steward of the tax dollars, and generally in how I run my own finances, I'm a consumer Best Buy kind of girl, where I'm going to get the non-name brand thing that has the best performance for the lowest price. So I'm also noticing in this chart that if you're testing every 3 to 7 days, so once a week potentially, that brings you to a 60 to 70% infection transmission reduction. Now you're saying you can test whatever you want, you can just decide, but we don't have any expertise here. We have some priorities we're trying to weigh, but like if I were to try to tie that chart with the minimal and the moderate risk of transmission, would you say that perhaps, the once a week testing is okay if we're in the minimal space? The consumer Best Buy version is if we're in the minimal space, whereas if you're in the moderate section or you're creeping, from moderate beyond, then you want to be in the every 2 to 3 day space. I mean, can you kind of, from a health expert perspective,
Right.
kind of talk to me a little bit about it?
Yeah, I look at it as tailoring your strategy, your testing strategy to risk. So when we look at testing, we look at prevalence. And so the prevalence of infection, the higher it is, the more you want to test. So it's as simple as that. And so when you're right now in a rising risk, you can probably get by with once a week testing. As we get around holidays and you're in that kind of the higher risk time, you probably want to do twice a week testing. And so, yeah, I would just adjust based on that. I think by the time, I think it would take several weeks for us to actually get this. So I think you're probably going to be in the higher risk category at that time. So I would plan for a twice a week strategy. You can always tailor back, but you don't want to start kind of half in and then, kick yourself that like, oh, we should have, you can always pull back.
Right,
So
right.
I think just considering the timing at which you're probably going to start this, maybe mid-November or whatever, is that's going to be a higher risk time.
So obviously we're going to have a process here of maybe multiple discussions and feedback from the community and all those kinds of things. But once we were to tell you, hey, we're a go, if that's what we decide to do, what then is the lead time? You kind of touch upon it be several weeks. So
yeah, it's really several weeks because we have to get extra supplies. So there are some supplies that are limited supply nationally. And so, we're not planning on doing an additional, we do thousands of tests per day, but we don't do, 3,000 additional on top of that test right now. So we'd have to acquire those supplies, get the staff ready to do that. And then we'd figure out, do you want one of us to help with the testing on site or whatever? And so just get that procedure. So yeah, there would probably be a 3-week lead time, 2 to 3 week potentially, depending on how quickly, if you could at least just keep me updated on if you're 80% or 90% there, then we could start that lead time so we could kind of cut some time down. But I would think probably we're looking at mid-November before we could actually realistically start.
Okay.
Both from your process and our process.
Yeah.
What are the requirements then? So I heard you say whether we would want you to come and do it. How would the testing work? Whether we did it once a week or twice a week, does your staff come do it, or do we run it and then have to deliver it to be processed, or what?
Yeah, so we do employer testing, and so generally, at least what employers do is, but that's the nasal test. We come on site and then we, test everybody. We'll have different shifts so that people can be socially distanced and things like that, and then we'll process, a certain number of people, per day, or per shift and things of that nature. Because this is an easier test, we can probably get costs down based on that. That's why I kind of went with the $35 mark, because I think we can cut a lot of the staffing costs down to get to that $35 mark. And what we would just, the lead, kind of some of the pre-work that we need to do is get people registered in our system so that as they get tested, they could just get an email or text notification automatically. And so that'll save staff costs in terms of, instead of calling every person, that they just, all the negatives will get automatically notified. The positives would of course be called. And then you would be informed as well. We can work on release and waivers and things like that. So we've already gone through this. So, we have an understanding of that.
Jess?
Yeah, so I think one of my takeaways from this document was that kind of there has kind of, the supply is an issue, and certainly it sounds like you're the only option at this point, and you're not quite doing it yet for schools. So it's, the takeaway from the document was that, there kind of needs to be this more clear guidance from the CDC about this kind of surveillance testing, because there's not like a real clear from all the way from the top down about doing this kind of surveillance testing. There's models, there's examples, there's best practice that's out there, but no one at official levels have said, this is what you should do. So we're kind of in this situation where we're trying to figure it out ourselves. And so the structures aren't really in place to have all of the supplies, because nobody said all these schools have to do it. So there's not these structures in place to have labs and to have the reagents and all the testing supplies and the staff and all that stuff. So that's not really coming together for us as schools. So I just kind of want to point out that that was a huge takeaway, and that's the challenge we're facing as schools, making sure that our students and our staff are safe, buttressed against the fact that 30 to 60% of infected people are silent spreaders, totally asymptomatic. They don't know. So I think one of the things that I also wanted to look at too is on page 17, for everybody following along in the PDF, there's also another chart there that talks about the case rates of how many daily new cases per 100,000 people. It says if there's 10 to 25 daily new cases per 100,000 people, that it would be recommended, based on this set of expertise, that K-5 students would come back, but not older students. Do you have any thoughts about why it would be K-5 versus the older students?
Yeah, I mean, the idea is that when we look at transmission, is that the closer you kind of get to an adult, you become more of a transmission risk. So even when we look at some of those flu data in terms of hospitalizations, and I said that there was no statistical difference between 18 or under getting flu versus COVID in terms of hospitalizations, ICU admissions, ventilator usage, is actually lower risk for COVID when you exclude 15 to 18-year-olds.
Okay.
And so 36% of the hospitalizations for COVID were 15 to 18-year-olds. So it skews heavily older. And so, I mean, I think, you're in a good situation in that, you don't have high school students, right?
Yeah, but we do have 6th, 7th, and 8th grades. So I guess going a little bit back to Jason's question, would you suggest if we were to bring back our 6th, 7th, and 8th graders, that they have a higher frequency of testing than maybe with our K through 5?
Yeah, absolutely. I mean, the data is pretty clear. They get it easier, they transmit it easier. It's a gradient. And so when you look at they've done multiple meta-analysis from around the world. And the reason why it's not as clear is because studies all across the world use different age breakups, but it's what is very clear is, I guess, 5th grade and under have a low, like kindergarten, through second grade have a lower transmission than third and fourth graders that have a lower transmission than fifth and sixth than seventh and eighth. So the transmission rates goes up. So I think it's a wise decision to test your sixth, seventh, and eighth graders more frequently than your kindergartners.
Okay, thank you. And this, if I have time for one more.
Go ahead, Jess.
Go ahead, Jess.
All right, so another takeaway, sorry.
You're
what-
pointing this direction. Is this?
Couldn't resist.
You guys can make the decision together. So another takeaway from this PDF was that 200 million tests are predicted to be needed for students and staff nationwide, just to address students and staff, and I think nursing homes combined. And right now, our nation, at the time of this report, is doing about 25 million tests. So huge gap. What is your sense of like what we're doing in terms of number of testings in DuPage in terms of surveillance throughout DuPage supports like the labs and the number of tests? And you mentioned point of care testing, which I don't even know what that is. So if you define that.
Yes, absolutely.
And how is that in the state of Illinois? If we're not seeing it at the federal level, are we seeing it come together and gel to have those structures in the state of Illinois or in the county?
Right, right. So those test numbers are monthly tests, right? So there's a far gap there, but what we're seeing is that we've consistently been 4 to 12 weeks ahead of the CDC, because it's kind of a lagging indicator because of a lot of the different pressures that they have. And so I think what we've done is we've invested in testing because we kind of see where the puck is going. We don't want to skate where the puck is going, not where it is right now. And so we've been expanding and leaning into testing as other people have been pulling back on testing. So our strategy has been to go with a completely US supply chain. And so there's much less bottlenecks. And so we can ramp up and scale up our testing. And then I think that's where you have an incredible first mover advantage, is because testing is going to be a scarce resource. And this is going to happen for longer than people realize. I think everyone is locked into this, a vaccine is coming and then everything goes away. That's not how it's going to work. Okay. And so having the access to whatever tests are available first is a huge competitive advantage. And not that you're competing against other districts, but you are actually for resources.
Against other districts.
You are. I mean, there's finite resources. Whoever gets it first is going to do it.
I just built a tree house. 2x4s cost $2, a year ago. Costs $7.50 now. It just is what it is. I mean, there's a shortage on wood, and then you want to get it, you're going to pay for it, and it's hard to get. So if you can get in line to get it, you get your order in first, you're in the queue.
Exactly. And the thing is, I mean, you may not know much about DuPage Medical Group, but we're the highest quality, lowest cost provider in all of Illinois. And we do that for all of our tests, all of our surgeries and things like that. So when we're doing employer testing, we've challenged our employers, look around, see if can you get prices lower than ours? And no one has been able to do that. And so we're giving access early, and we haven't had anyone beat our price point earlier, but again, we welcome it. If people can, if they develop it internally and they can do it, great. There's plenty of demand. So I'm not coming here saying that, hey, we really need to do this thing. This is not a financially motivated. There's plenty of demand on our end. The question is, we would love to partner with people in our community, because that we feel is part of our calling, And so, but ultimately you have to do what's right for, students, staff, yourselves, financially, all of that kind of thing.
Doctor, could you address, Jess raised a good point. You'd used the term point of care testing.
Yes.
Do you want to just quickly describe what it is? And then Jess, I don't know whether you had any other comments. But.
Yeah, so point of care testing, what that means is someone can test themselves and get results in 15 minutes, like a home pregnancy test.
Mm-hmm.
So they're called lateral flow tests. This is actually what got the White House in trouble, is they were doing frequent testing, but not necessarily doing it in the right way. And so, when you'll get a false negative if you do it too early, and then that gives you a sense of confidence, but then you can still spread. So the timing is important. It changes with point of care testing versus PCR. And I think that's a nuanced point. So it's basically a test that you can do on your own, like a home pregnancy test.
Okay.
Thank you very much. I appreciate that. And I think I think you called it the first mover advantage, the competitive advantage. I think that's something that I want to emphasize too for everyone that's watching, is that our district seems to have a lot of challenges in terms of space, mainly space, in getting everyone back to school. And I think when we think about what's going to happen for the rest of this year and for next year, even for next year, everyone, we don't know if we'll be back to school normally. And this could give us a pathway back to that. So I guess I do have a follow-up question.
Bill,
I'll have 14 minutes.
Jason has given you an exemption to ask another question. Go ahead.
Talk about the safety of our kids. Let's go.
We talked about layers, right? Layers of strategies. 6 feet of space keeps half of our kids out of the building at any given time. If we're doing a testing strategy, does that remove the need for that?
It does mitigate it. So the 6 feet distance, I mean, I think this is where there's a lot of misinformation in the media out there, is that I think what people aren't appreciating is that there's an aerosolized component to this spread.
There's a who's it?
The virus can hang in the air.
Oh, yeah.
And can travel further than 6 feet. Okay.
Mhm.
And so masks are more important than distance, and testing is more important than distance. So those two things are. So if you add hierarchy, like higher level prevention strategies, then you can squeeze a little bit other things. And so you can get more kids back to school, potentially, you know.
Potentially, yeah. We would certainly have to work with the health department on that, but thank you.
But I mean, I like the fact that they gave a lot of wiggle room and a lot of flexibility, encourage this, encourage that. So we do, so you wouldn't be the first school that we've worked with. We do work with a couple private schools, and, you know, they've been doing great with their strategies as well. So it is doable.
Thank you.
Thank you. Thank you very much for indulging me in so many questions.
Okay, Guillermo, let me open the floor to you.
I think some of my questions were already addressed. They were mostly around the setup and logistics. But I did have a follow-up on the comment, Dr. Philip, that you made on the testing is a scarce resource. And just to clarify, is this testing mostly being driven by the universities and the medical community, or the manufacturers also jumping on it to make sure that we get the supplies that we need to increase the testing?
Yeah, so there are a variety of factors that have led to scarcity of testing, one of which is kind of our global supply chain, is that things had to come from all over the world in order to initially do testing. And so when there was a bottleneck or an outbreak in one part of the world, it kind of, you know, threw the whole supply chain out of whack. And so that's why we're kind of sticking to just a US supply chain. And so it's a scalable solution. We're also, Saliva Direct is slightly orthogonal to a straight nasal PCR. And so even if there's a run on reagent, we can still secure Saliva Direct ability. There are still some bottlenecks, but much less so. So, you know, so we're definitely actively working around that. And we've been able to navigate that well so far. So we're hoping to continue to do that.
Thanks.
Is that good, Guillermo?
Yep, thanks.
Yep. Good. Dr. Philip, first of all, thank you for the time.
Yeah, thanks for that.
Patience and clarity. I wanted to go back to the Yale test. Yale was authorized, got the emergency authorization for Saliva Direct. So are you in the process then of, and I know that they've open sourced their protocol and they've invited labs and medical groups to essentially opt in to work with them. Is this a licensing agreement with them? What exactly is the agreement with Yale Saliva Direct? And then when do you anticipate actually having that in hand?
Yeah, I believe we have been working directly with Dr. Weil, I believe.
Yes.
Yes.
Yeah, Ann Weil.
So yeah, Ann Weil, exactly. Really for the last several weeks on being licensed with them. I believe, I mean, our lab director has been having those conversations directly. And so as far as I'm aware, that's, you know, fait accompli, it's going to happen. But either way, we're in direct communication back and forth directly with Dr. Ann Weil.
Okay. And are you required to do a bridge study with Yale to be able to, for them to extend the EUA to your lab? I know they're now doing that in other states, and I was just wondering whether that's part of the process or whether you know.
No, we're trying to simplify things as much as possible. So the more complexity we add, there's more things that can go wrong. And so we're not required to do a bridge study. They haven't required it. We're not requesting that. So there's kind of a clear lane.
Okay, okay, that's great to know. Real important to us, whether it's once a week testing or whether it's twice a week testing, is going to be responses come back very quickly. I have felt really fortunate to be an employee at the University of Illinois. I've been repeatedly tested and I get my results back within 6-10 hours. And that's after, you know, they've got everybody back on campus. That would be really important to us, the turnaround time. Is that what you would anticipate also, that we would be getting results back within 12, 24 hours?
Yeah, I mean, we anticipate within 24 hours. We like to kind of under promise and over deliver, but it really depends on so many factors, like how many tests are you going to do and how many shifts do we need to do? I mean, we can do 24-hour shifts if need be, but without knowing how many you're going to do, when you're going to do it, it's really hard to get timing. I know that currently all of our in-house testing is within 24 hours.
Okay.
Or sooner, but because it's automatic, as soon as the test results are released, they can, you know, it's not like everyone gets it in 24 hours. I mean, some people may be getting it in 6-8 hours. As the batches are run, it'll just keep happening. But I would say probably latest 24 hours. Okay. But again, without the numbers, it's hard to tell. Yeah.
And for whatever the price point is, and that's still, that would be need to be determined and worked out, you would have DuPage Medical Group staff at our schools, if I heard correctly with the previous question and answer, collecting the sample and then taking the sample to the lab that you're using to run the test, as opposed to our nurses or volunteers. I mean, again, at the University of Illinois, you've actually got undergraduates who are able to do this because it doesn't require a professional. But I think is that true? I'm just clarifying.
Yeah, I mean, that's what, there's so many factors with pricing. And so, I mean, you may say that, hey, it's going to be cheaper for us to just have the kids spit it in their own cup, you know? Like
I see.
You know, so like, we can do whatever you want us to do, but, you know, I think that's to be determined is what do you really want us to do? I mean, we can definitely have someone here helping facilitate, but, you know, testing every single student would just add costs. And I think that's easily reproducible, and so you probably wouldn't want to add that cost. I mean, it concerns the Best Buy shopping, you know. Yeah. I mean, that's what I would do. I would say, like our goal is to equip you as much as possible to do as much as this on your own to keep the cost down, and then we can process the lab. Like, let's do what we're, you know, our expertise, and then allow you to do things that, like, why do you have to add that extra cost? But we can. I mean, some employers have asked us to do that, and we surely can. But again, you know, I'm not trying to run up the costs here. And so we would always give you full transparency and like, hey, this is how you can get the cost as low as possible.
Okay. Okay.
So just to follow up on that, is this, not to get kind of gross, but is this kind of similar to the pee in the cup test where, you know, but I mean by that is that, like, you know, you're all like, we all kind of pee in our own cup and that doesn't affect the viability of the test. Like if we're worried about a kindergartner spitting in his own cup, you know, are we worried about, and then what does the kid do with the cup after they spit in it? You know, just like, you know, the urine test, you're not worried about what happens from the restroom to walking it back to the counter. Are we worried about that kindergartner or how they walk back to the nurse's station or wherever? Is there any effect on the viability of the test depending on the procedures that are implemented?
No, it'll be fine. Yeah, if they get it in the, you know, sterile cup or whatever, we can still run that test. I mean, that's the advantage of being in the neighborhood too. I mean, we would just take the test and run it right here. We're not traveling a long distance, so there's not a lot of delays, and then we would process it right then.
Okay.
Yeah, so that's fine.
It's worth noting, and I'm sure we would insist on it here, that the Yale saliva direct testing and the testing done by the University of Illinois also requires that the tester avoid drinking or eating, even brushing their teeth, within 30 minutes of provide. So, because if they do, it doesn't generate a false positive or a negative, but the test is just not, it's just not rated. It doesn't come through as a valid test. If you've eaten your Cheerios and then you spit into or drool, right? So those are guidance and directions that will have to be provided to people, along with labeling a tube and putting it properly in a bag. Okay. Well,
can I ask a
follow-up? Add a couple more follow-ups.
Yeah, well, certainly.
Jessica doesn't have anything.
Let me just go back real quickly, just before I get to you. Let me go back. Bruce, you've listened to some back and forth, maybe it triggered one more round of thoughts or questions for you.
Well, I guess what would happen if a student or the student's parent decides that they don't want to participate in the test, but they still want their child to go to school in person?
That's what I'm
But-
asking.
I don't know if that's a test for you.
Yeah, I think, I think,
As a board, we'd have to probably think about that, or,
well, I think the board would have to establish a policy that if one possible option is that if students are going to enter the building, staff is going to enter the building, we're talking students in this particular case, they would have to agree to participate in a testing protocol as a condition for in-person learning. That's true at the University of Illinois. If a parent was uncomfortable under any conditions testing, then they would default to
Yeah.
remote. That's one.
I think the big difference there for me is that, the University of Illinois, you have to be accepted there. It's not private, but it's semi-private. And I wouldn't want to deny a student in-person learning that they could normally get if we weren't testing, because we were masked up and, doing our remote. So I'm not saying it would be a big deal. I think most parents would probably, agree to test, because I would like to know if my child had COVID or was beginning to have beginning to have it. But I could see some parents, probably not a majority, probably a very small minority. Maybe it's just something to consider or think about as we move along with this.
And that is something
From a
that we,
testing perspective, from looking at it from your perspective, from a statistic perspective, what impact would that have? And is that the best course of action to say, no, don't come in the building like they're doing at U of I? Or is there a different course of action that would be recommended?
I think we're requiring our daily self-certification. So if a family doesn't do it 3 times, they're automatically in remote. So I don't know that this would be that different.
whatever we decide to do, I think we can defer that for the conversation that we would have about what kind of a policy we would go forward. In terms of your contribution, I think Jason's point is, if you mind my restating.
No, go ahead.
the point, that if you have a large group of people who are coming into a space and they are testing, but you have a minority of people who aren't testing, it likely has a negative impact on the validity of the testing.
It does. I mean, there's kind of like this herd immunity mentality, is that if you're testing everyone, you can make sure. But if there's like 5% of the population that could be those super spreaders,
It just gets rid of the viability of the test.
I mean, yeah, it minimizes it a little bit. It's not a huge kind of thing, but it depends on the percentages, really, because it's just all probabilities. But it does minimize that.
Okay.
Yeah.
I'd say you're not getting money's worth. Then.
I'm just asking the question, the effect on
Yeah.
the testing, the viability of it.
Bruce, anything else?
No, that's it.
Thank you, sir. Let me go to Guillermo then too. Our virtual board members here.
No further questions. Thank you, Dr. Philip, for taking the time and for sharing the information with us.
Sure. Thank you, Guillermo. Ted?
Nothing more. Thanks.
Sure, okay. And Jess?
Okay, I have two. So I'm just imagining all the kids spitting in the sterile cup here. And we were talking about layers and strategies, and it's just okay, now we're going to have a room full of kids with their masks off spitting.
That's,
I'm guessing
like-
it's not a
that's
room.
not how we will be doing it.
I know.
It's not a lunch table.
Promise
It's
you
not
that.
going to happen that way.
But
More-
how do you do that? Are you outdoors when you're spitting? How are you doing?
No, I mean, that's something I think we could work through. But
Okay.
there may be an area where the kids walk into a room, spit into that area, walk out of that room, or there are different ways of doing this. But yeah, you wouldn't want a bunch of people without masks in one area. It would
For
be
sure.
kind of single file. And that's why the idea of stations, you may have a variety of different stations doing this concurrently. So there's not this huge line. And so I think there are ways of thinking through that. But it would really be tailored to kind of your workspace. Sure.
Okay. And then another thing that stood out to me in this PDF, and I don't know if it's a question for you or for our staff, is the idea of wastewater screening.
I thought you noticed that.
And so the idea is you monitor the wastewater to see if there's
Mhm.
COVID in the wastewater, and then you know that you've got a case. That seems cheaper and easier. I don't know. So like, is that a thing we're doing in Illinois? It's being done
Good.
somewhere?
It's being done.
It is being done. I have read accounts of it. I do not know whether that's something the county is doing or whether anywhere, any place in Illinois. Are you aware of?
Yeah, I mean, I've seen that. I don't know of anyone who's actually doing that. It's a theoretical test. The yield is a lot lower. So it just tells you that there is a case
Right.
or something. But when you pool in that way, you're going to miss a lot. And so you'd have to have a significant number of positive cases before that triggers a positive. And so it could be done. We don't do that. So that would be something you would do with the county. That public health departments do that.
Right.
At that point, you're talking about having an outbreak already by the
Yeah, it's
time
going to be
you
an
find
outbreak.
it.
Yeah,
Probably.
So that's a good way of saying that's to determine where an outbreak already is, not like, are we preventing an outbreak?
Yeah.
By that time, it's too late. Then you're remote, 100% remote.
Okay.
I think
Fair.
I think there are like dormitories and stuff.
Right.
Like in the dormitory level at
You might.
colleges that do that. And again, if you look at page 17, they talk about environmental or pooled surveillance, but only if
Yeah.
you're in the green, which is very low level. So basically what you're trying to do is capture unforeseen hotspots, and then you start doing more targeted testing, if I read that correctly.
Yeah, so screening the wastewater is better than no test whatsoever. Like if your choice is between
Right.
no test and screening the water, you can start screening the water.
Yeah.
Right, but I think the point here is that if your community infection rate is high enough, you don't need to do any of the pooled testing because you already know that
Because you already
It's
know.
in there.
that there's enough of it in the environment.
Mhm.
Now you're trying to find the individual cases versus just identify how the prevalence.
Makes sense.
Like say it was positive, then what would you do? You'd have a testing strategy.
Yeah.
Right.
So I mean, it
Right.
doesn't
Right.
solve anything for
Right.
you.
And if we're not already in the program, it's going to be really hard to get into the program because we're going to find ourselves in a situation where we have scarcity of tests.
Right.
Unfortunately.
Jason, any final thoughts?
Yeah, I want to jump back to Bruce's comment and just kind of piggyback on that as to, in a nutshell, like from a Reader's Digest perspective, HIPAA compliance, how does that work with the testing protocol and delivery of positive results and delivering that information to the school community?
Yeah, so at least, I don't know if there's a different thing with pediatrics or things like that. I mean, obviously parents would be the decision maker there. But what we've seen with employers is that legally their employees would sign a release that if there was a positive test, that they would be notified and then the employer is covering the cost of that. So that's legally how they've done it. Obviously, have your own legal counsel review that, but generally speaking, that hasn't been a problem.
Okay.
Because it's kind of shared risk. So if everyone would want to know.
I just was wondering just how that's been dealt with.
Yeah, but so then they sign a release basically that.
Then, and thinking of the timing of this and looking at the mid-December or mid-November,
November.
and then looking at, so say we do this, and then you go into Christmas break or winter break, sorry. What would be the protocol for coming back to school from a break, from a testing perspective? Would you start up, say Jan 4, whatever that date is, or do you start up or testing up like December 29th or something like that?
Yeah, I mean, you could really do it either.
I guess what's best practice, I guess more of what I'm asking.
Yeah, it's, there is no best practice. That's the
I
problem.
guess that's true. We're in a novel pandemic, it's a novel
exactly.
coronavirus, there's no best practice.
We're trying to
It
create
takes a
one.
lot of creativity, but basically, you want to test no sooner than 5 days after exposure. And so if you test, let's say, I don't know, December 29th, you would.
And I should make up the dates.
Yeah, but let's say, and you say you're starting school January 4th. Let's say you start 5 days before, so you get all the results. That's great. But then if they were exposed in the meantime, then that's going to show up further. So then that would be like an additional test. You may say, okay, we do our Monday, Thursday test, but now we're going to do one at the end of the break. I mean, I guess you could do that, but you probably wouldn't need to.
You're saying it's randomized enough that you're picking up X whenever you're doing your testing.
Right.
And if you're doing your testing, whenever you're doing it, you're to pick up those tests that exist then.
Right then are positive, right? Like, so that's why like maybe a Monday, Thursday, or, strategy makes sense because people come back, they get tested. If they were just exposed Sunday, the Thursday catches them. You know, because it takes a few days to actually become infectious. So even if they're exposed on Sunday, they're not infectious Monday. You know, so it's not perfect, but
Nothing is right now.
nothing is right now. Yeah, and you know,
Okay, okay,
Okay.
great.
Those are my last two that I recall for now. Thank you so
sure.
much for coming
Yeah,
out.
no, thanks for the opportunity, and wishing you well.
Well, before we let Dr. Phillip leave, although I can't keep you here, you're welcome to leave whenever you want.
Sure.
However,
Thanks for acknowledging that, Bob.
I would like to turn to my board colleagues and see if there is consensus enough to direct the administration to follow up with the Page Medical Group to discuss, negotiate what a testing plan might look like, so that something could be brought forward to the board that would be fleshed out, where we could consider it perhaps by our next board meeting, which would be at the end of October, which if it all worked out and you got your licensing from Yale, given the 2 weeks that you would need, that would kind of put us into 2 to 3, that would put us in that mid-November possible range. So let me just ask the board if there is a consensus to direct the administration to follow up, to bring back a more fleshed out plan for us to consider, okay? So,
Can I ask clarifying?
Yeah.
And would the idea be that at the next meeting, we would vote on that, or we would introduce it and then vote on it?
well, I think we could do it either way, depending on how fleshed out that is and any additional questions we might have. That could be a night that we could take some action to possibly adopt, or we could then hold a special meeting between then and that first meeting in November. So we can give ourselves some flexibility to do that. Yeah. So
Can I
let me,
ask another question? I'm sorry.
sure, Guillermo.
Don't be sorry, Guillermo.
I'm sorry, Dr. Phillips. So I'm assuming that we're not the only district that are looking into these solutions. And based on the supply and demand comments that you made, that we don't want to fall behind, right? The waiting line, is that correct?
Yes, we are in discussions with other districts. You're right.
Okay, thanks.
I would hope so.
Okay, so let me just
Yeah.
Go-
sorry.
go around the board and just see whether we've got a consensus to allow some further discussion and then to bring back a possible plan to consider. So let me turn to Ted.
Yes.
Ted, thumbs up. Jay? Yes?
Yes, but I'd like to see a special meeting after.
Your
so that
preference
we have
would be to do it in
two-meeting room.
that. That's
Yeah.
duly noted, Jessica. Thank you. Let me go on line here. Bruce, you're up.
Yeah, I'd like to see the cost vetted out and then have a special meeting so that people from home could think about this, see what we're planning, and then look and get feedback from the public.
Thank you, Bruce. Appreciate it. Guillermo,
Yes.
okay? And Jason.
Yeah, and I think it's twofold. I think that, yeah, I think it makes sense to continue this conversation. But I think it makes sense to continue this conversation about, as long as it's paired with, and then what's our strategy in using that information, and how does that impact, our providing an education to our kids? Because I think they both have to go hand in hand.
Yeah, that is most certainly the case and worth stating. Well, I'm also in agreement to direct the district. So,
Did you ask Guillermo?
did I get everybody?
you said yes.
Yeah, Guillermo, I did ask you?
Yeah, you did. Thank you.
Thank you. Ted's always looking out for you. He's ahead of you. He is. Thank you, Ted. All right. Well, very good. Dr. Phillip, I know you're a working MD. It's been a long day for you. We really appreciate you having this conversation with us and our community. It's an important decision for us to make, and it's helpful to know that we've got partners out there in the community that want to work with this school district. So thank you.
Absolutely. Thank you for the opportunity.
All right. Appreciate it.
Thank you. Thank you very much.
Thanks so much.
Appreciate it.
All right, Dr. Kiskowski, I
You
think
did
you've
much
got
better after the water.
maybe one or two things yet to do.
All righty. Okay, so our next update, we're going to ask Laurel to join us through the Zoom. And she is going to give a quick update on special ed.
Thank you very much, Melissa. I appreciate it. And thank you, everybody on the Board of Education for having me come to give an update to you this evening. I do appreciate you having me here, and I'm happy to kind of just share a brief update as far as our special education services go and how we've been looking out for our students who have special education needs, and also our students with 504 plans. And in addition, keeping that broad scope on all of our students. I'll just hit some highlights for you this evening about some of the things that we began doing this summer and thinking about our preparation, and even as we concluded the school year last year for our students returning to us. We started right away in June in looking at our social and emotional concerns for all of our students, and that of course includes then our students who have special education needs and or who might have a 504 plan. And through our ability to be able to create a reentry team for social emotional learning following or I guess really during, but in the anticipation of returning to school after the COVID time period when there was the shelter at home and then the remote learning, et cetera. We met with a team of our own social emotional health professionals, social workers, and school psychologists and counselors, and started to work on surveys for our families and for our students, and just wanting to make sure that our staff and everybody could come back making those connections that they need to make, and that we could really help from like a tiered level of interventions and preparation upon that return to school. That has been really I think, a positive for our D41 community, because as we have continued to meet, once we started back in our remote learning model, our team has come back together and been able to talk about how within the buildings they have used a tiered approach to help respond to some of the concerns that came to us through those surveys of our families and our staff. And we're continuing that work as we begin our return to the blended model too. We have been thrilled to have all of our special educators, our teachers, and our related service providers be a part of the digital media training. Our digital literacy specialists were just fantastic in thinking through and planning and preparing for professional development that included all of us to make sure that we were addressing the needs on Google Meets and on mini meets and ways to really make sure that we were pulling our resources and using or optimizing the way that we use those technology tools so that we could meet the needs of all of our students, particularly really honing in on those students who have IEPs and who have 504s and might need a special education teacher co-teaching or joining in on a particular lesson, and also those teacher assistants or paraprofessionals being a part of helping to cue students or helping to pull students into lessons, even though we have been learning in that remote platform. Likewise, something that has been fantastic for our students with special education needs is that early on, I was able to engage, and Betsy Buckley, our special education coordinator, assisted me in this, in engaging our different groups of professionals. One of the groups, as an example that I will tell you about, our speech language pathologists, to make sure that we could really inquire from them and learn what sort of technology tools they may need to be able to make sure that they could provide those services remotely, and also as our students come back into that blended model. So we were able to take a look at our licensures and our evaluation tools and everything just right away in August before we came back to that educational setting, so that we could prepare for the best use of our technology platforms for our students. And where students needed something different or something really specific for their special education need, for their IEP, we have encouraged parents, and I've been able to authorize assistive technology evaluations so that we can do specific dives into what is appropriate or what is necessary for some of our individual students based on their own learning needs.
Also, the paraprofessionals, that's been wonderful to work with them as they have been innovative and working with our special education teachers. And we've had additional training sessions just to talk about methods and some unconventional ways to continue to work with students, especially in the remote platform, because that's a place that we want to keep returning to and thinking through and reflecting on and learning from how we can keep growing our own abilities to be able to work with our students who for some, as you know, the remote platform has been wonderful, and for others have had some difficulty with that engagement or that connection to the instruction. So that's been a key for those students in special education. One of the things that our case managers, I give just great kudos to them for working with those assistant principals and together reaching out to our students, particularly our littlest learners, and also some of our students who we anticipated and through our connections with families knew may have much more difficulty with that social distancing and also with the ability to be able to wear a mask or sustain, tolerate a mask for any period of time. And so that was another area that we focused on, that outreach early on, and have continued to focus on that to help build the ability and the tolerance and the understanding, particularly for students who have, again, some of the students with IEPs, some of the students with 504s, for whom they may need some additional modeling or some social stories. There have been videos that have been made, and our parents really have been great partners in continuing to talk with us and help us understand the progress that each of their students is making so that they could be ready to return for that blended model. We've also invited our parents in that regard to join through our case parent universities that have been provided for some additional tools and techniques. And I've been working with the SPAC co-chairs because we've been talking about some additional sorts of resources. They're looking at their calendar now, so we can build that and have some resources and some opportunities for some mini virtual coffees, as you will, or if you will, to talk about some topics that are of concern for parents and where we can help again with tools for them. In addition, we've redesigned our homepage on our student services page on the D41 website to offer some of those same tools like the videos for mask wearing, et cetera, for our parents. So all in all, for our students with special education needs and our 50 and students who have 504 plans, we have focused on individual remote learning plans, and you may have heard this term. It is a term that I think was new to all of us in about March of 2020, but it was born of the need because of COVID-19 to have to make sure that we are honoring that governing document of the individual education plan or Section 504 plan for a student, but really looking at it through the context of our limitations because of COVID-19 and because of our requirement to provide some of our services through remote learning. I have been again impressed with our building teams and would ask for our parents and our community to continue to reach out and work with those teams, our teams to continue to reach out to our parents, because we really set the bar high in District 41. We asked our individual remote learning plans to be written for every student as we were returning from spring break last year. That was something that was very important to me and Alyssa and Katie and our leadership team to say that for Glen Ellyn, District 41, we wanted to make sure that our students were really able to access their education, and we were able to strive to meet all of their needs academically, socially, emotionally. And while it may look different, that's the purpose of that individual remote learning plan. It may look different during that remote time or that blended time period. It still is something that is built to look at what each child needs based on his or her own individual needs. And so when we returned for this school year, we did it again. We used the progress that we knew about from the springtime because we had fortunately learned, there's a silver lining, learned through our forced remote learning in the spring how some students responded, and we could use that to help revamp those plans and work through what would best meet children's needs as we started this school year. And we'll continue to do that. I look forward to continuing to do that. But our focus, even as we started this school year, was to look at it for complete remote as well as blended. So those plans have been built for each student in that way.
Laurel, thank you. Thank you. Let me just quickly turn to my board colleagues and see if they have any clarifying
Thank you.
question. Ted, any questions for Laurel?
No questions.
Okay, thank you very much. Guillermo, any questions for Dr. O'Brien?
No question. Thank you.
Thank you very much. Let me just stay online there for a second. Bruce?
You're on mute, Bruce.
You're on
Bruce,
mute,
if you have any
Bruce.
questions.
There you go.
No questions.
Thank you, Bruce. Thank you very much. Jessica?
Yeah, when you are doing those individual remote learning programs, and you said you wrote them in the spring, and then you wrote them again upon our return in this fall. Like, can you kind of just give me I don't know, like in terms of all of our students and our families that you have to meet with, what's the timeline when you start to when you kind of get through them? Because I know in a typical year you're always doing them, but kind of like, you can't do them all in one day, right? So kind of what was the timeline in terms of getting from student one or family one to the last family?
Sure. I can answer that question globally. Jessica, I'm gonna try, though I think I understand what your question is, and if you need me to clarify further, let me know, please. From a global perspective, when we started them the first time in the spring, I was, learning as all of us were, everything about what the requirements would be under IDEA and of course IDPH and ISBE, et cetera, and taking a look at how and what we should expect of our IEP teams and our 504 teams as well, but I'll focus on the IEP team aspect of it, particularly in the spring. And so as they returned from their spring break, literally everybody, we asked them to begin working on those right away. And when I said globally, I couldn't tell you an exact date. I'd have to look back in my notes, but it was a week or 2 week time period, as I recall, in April, that we said, okay, here's, because we needed to really work and help train the professionals what to look back to, to look at that IEP, to look at what they knew right now about a student's progress before that home order, and then even the little bit of knowledge they had once they had started working with students for a short period of time. But I think it was a couple of weeks, maybe about the middle of April. And for the most part, they were able to meet that. They worked really hard to do that. There were some situations that were a little more complex, and our teachers were very responsive in saying, we'll just keep working with the student, of course, but work with the parents to collaborate and kind of figure out what else needed to be done or how we could make sure to meet those needs. As we stepped into this school year, the time period and the expectation for our staff was pretty quick, because as they returned, we had, I might be wrong, but I think it was 4 days between our institute days and planning days. Marcy or Katie could probably correct me on that. If I recall right, it was 4 when our staff returned and then the students were coming. And so we were asking them with their caseloads and based on what they already knew, because fortunately they'd had that experience in the spring, to look back at those, to look at the IEPs, and to kind of reconcile everything with a student's progress. And fortunately, they already had some information they could use, and then some things that needed to be changed. So most of the students, as they started the school year, our teams had drafts ready to go, but it didn't mean it was finalized. And for some of our students, again, with those more complex situations, that did take a little bit longer into that next week, I know for sure. Our parents always, at that moment in time, and still to this day, We welcome them, though, if they want to come together at the table and really talk about it and collaborate on it. And parents have done that, and I've been fortunate to be a part of some of those conversations. I have to say, I feel very fortunate because in every one of those conversations, even though they can be hard because we're worried about our students, each one of them, we've found just wonderful partners between parents and teams and trying to just figure out how we can help make changes for individual students. So some have taken longer, but if that gives you an idea of a time, it was really pretty immediate. And then depending on the circumstances, it took a little longer if and when we came together to talk about it more deeply.
So I just want to make sure I understand correctly. So it sounds like within 1 to 2 weeks, you're rewriting those plans and you're also meeting with the parents as part of that process.
Yes, however, not in all circumstances was the meeting with parents, because there were some they're all done as amendments to an IEP unless the parent wants the meeting. And some of them didn't require that, but they did have communication with parents in all cases.
Okay. And we're talking about like 450 plus plans.
It's right. It's about across the district, about 430, right around there. And I just, as I guess, a little reminder that I think should be very comforting is that the IEP or the 504, depending on what a student has, it continues to be the controlling document. We continue to hold our annual review dates for each one of those. We are continuing to follow all of those expectations under IDEA for those procedural safeguards for parents. So those documents, should we, and of course we all hope in due time, come back together in the buildings in person all of the time, we are not letting that piece go. That piece has to still comply, and we want to make sure we keep that up to date so parents can have a comfort, I think is the best word, in knowing that when that time comes, that cycle will have continued for what we think that each child needs in that full person setting.
And that annual review is something that happens throughout the whole year, right?
Correct, all
You're
throughout.
rolling them all the time. Okay.
Absolutely, yes.
Thank
Thank you.
Thank you.
Yep, good. And Jason?
Just a few. I want to start with our return to school. So we're going to start, fingers crossed. Well, we're going to start bringing kids back to school this week with our kindergartners and second graders, and then with our pre-Ks starting next week. And then, fingers crossed with some of our older kids beginning November. Obviously, we're going to see some challenges presenting with a number of our kids, both our remote kids and our hybrid kids. Because you're going to see remote kids that are going to show issues with different class rosters, what have you. What is the district's plan on looking at, achievement gaps, learning gaps, issues that have arose during this remote period when kids return, or with these kids still staying remote? What's the plan to address that and implement supports going forward?
So our IEP teams have been looking at the progress and looking at students based on, whether or not they're making progress, whether or not there's regression as we're going forward. And they will continue to do that. We do want to make sure that if there are needs that we need to address differently with students coming to blended, or also to the extent that parents may have chosen that option for continued remote learning, we want to make sure that we do look at a variety of data markers to determine what else a student needs. It's definitely a fluid process.
Let me piggyback on that, and I'll go back to my original thought process. But when you're looking at data markers, are you seeing any gaps where there's something that that our district needs help with, or anything of that nature? I know I just completely threw that out. Even you said data points, it brought that to my thought process. Is there any place that we're lacking?
Not as a global, not as a pattern. I'm not seeing that, but certainly willing to keep looking at it, or if there's something
No,
that
no,
you
I'm just,
feel
when
like
you
they
said
want
data
me to
points, you
look
just brought
at.
it up. But obviously, when we're talking individual kids, you're going to see individual issues. And I think it's fair to say that that IEP is going to control for individual kids. And have you seen flexibility throughout our district and with the IEP teams and the staff as to helping address those kids, I mean, each individual's kids' needs?
One of the things that I think is really remarkable, and I can't stress it enough, is how our IEP teams are so caring about kids and have been in this process. I always feel a little bit, I guess, almost humbled by it because they want to figure out what each child needs and figure out what else we can do if there's a need there. So that is something that I'm noting in each individual case in which I've been involved.
I think going back to my original thought when talking about bringing kids back, I think it's fair to say that you're probably going to see some more kids that are going to present, more learning issues coming back. What is our plan for those kids that may not have presented any, but not that, learning disabilities or anything, but just definite gaps in learning that are returning back to school?
Yeah. Jason, I'm going to jump in on that.
No, that's fine. And she might not be the correct person to
Yeah.
ask. So, and it's
Right,
that I
if it's-
apologize. I'm not trying to throw, the questions at.
No, I don't want to make that, that shouldn't fall on
And that's fair. And I
special ed
apologize, Laura.
department shoulders, but, that's where our assessment plan and our intervention time becomes key in terms of detecting and addressing any learning gaps. And obviously, that's where testing protocol, is important for us because, the one thing that we keep coming back to is space issues, and our ability to bring more kids into the building at any one time is significantly hindered right now. So I think part of what the district has to tackle is how can we safely do that? Because, we are with 50% of our kids or slightly less when you consider those who, with remote, who are choosing to stay on remote, we still have significant space issues. We're trying to find every little nook and cranny for kids who might have to learn in an individualized workspace. Space is a challenge. So anything that we can do to mitigate risk and, and bring kids back differently or not be so bound to the limitations that we're under right now. It's going to come down to, until we can, it's the quality of our interventions. It's assessment and it's intervention for kids that are showing any kind of gap because, we have 2.5 hours in person and 2.5 hours remote. And somehow that's where we have to figure out how to make it all work.
And I think this is hard right now. And I think that, to be honest, and whether it's having the conversation with Laurel or with Katie or with yourself, it's not going to get easier in the next few months. It's likely to get harder. And that's why I asked about when she brought up data points as to, were there any gaps? Is there something that there needs more support here, needs more support there? Or is that may be a better question to ask, come January?
Right. I think it's going to be, what can we do once we're able to use our space differently and perhaps have more than only half of our kids back in any one time. It's how do we use our space?
And flexibility in that, it sounds like, is as well.
Did you have any additional thoughts, Jason, for Laurel?
No, and like I said, I wasn't trying to put the wrong question to the wrong person. It kind of seemed to go, the conversation go to the same place, so.
Okay, thank you.
Yeah, I mean, and ramping up, we have a tiered intervention system, and at some point in time, when we're not under the extensive restrictions that we're under, whether that's later this year or over the summer, the board had already asked, would we be willing to look differently at what we could do this summer? Let's hope that when the summer comes, we're able to use our spaces and make the most of that time, because right now our hands are kind of tied with so much of what we can or cannot do. And we know we're likely going into another period in time where it's going to be rough.
And I think that as a board, we have to be open to that conversation. And as Bruce brought up before, you know, when you talk about the cost of testing, when you talk about the cost of a building, we may have to look at, you know, prioritizing things. And I think we have to, I mean, that's just a conversation you have to have. And if looking at different things for different summer
Mhm.
programs, what have you, that's something, the conversation that we have to have.
Yep, Right
Yeah.
now, the priority, I think, is keeping the buildings open.
Of course,
You
yeah, I would
know,
agree.
we can do things with kids if we can be here in
Yes.
person. So I think the priority for us is the most we can do to be proactive and keep the schools open will help us.
Yes. Okay. Laurel, thank you
Thank you, Laurel.
so much for joining us.
Thank you
Appreciate.
to all of you. I appreciate it very much.
And Dr. K, I think you have one more.
And,
What was
and
that?
Marcy, thank you for hanging in there. I know you've got a quick staffing update.
Yeah, nothing much, just to let you know that we've been meeting with principals and looking at student numbers for remote and in-person, the in-person hybrid. And so we are, we will have some staff that we will have to add to make this work. Because when you take kids out of in-person and you put them in remote, it doesn't mean you can always move a teacher. Because of the way numbers work to go to a remote section. So we are working through that. We are, for right now, for the K through 2, we're in pretty good shape. We just are looking for a kindergarten teacher because the remote numbers changed on Thursday quite a bit with parents moving children into remote. So that is one area that we are trying to get staffed right away. And then the 3 through 5, we are still monitoring those numbers and looking at it, but we will have some additional staff members that we will have to hire for the junior high and probably one for the 3 through 5.
Let me just quickly, board members, any questions for Marcy, Ted,
No question.
Jessica?
No, no questions.
Okay. Bruce, any questions for Marcy?
No, not right now.
Thank you, sir. Guillermo, any questions for Marcy Conlon?
No, thank you, Marcy.
Okay, and I was going to see that Ted's got me so sensitive. I almost called on you twice in a row. Jason?
Just one, Marcy. With the returning some kids to school in this hybrid model, does that have any impact on our social workers? Because obviously they're going to have a decent amount of work, but I don't know if the hybrid/remote affects their workload.
It shouldn't affect their workload. They still will continue to work with their same caseload that they have. We have looked at all of that as well to determine if we needed to add. We don't believe that we'll need to add in social work, but we are looking at speech services to make sure that we're able to accommodate everybody in the
Right.
in the mode that they need to be taught in, you know? Yeah.
I understand.
Thank you, Marcy. Thank you very much. I'm good. Melissa, anyone else?
Nope, that was our last, just want to share really, really quickly that the work of Pratt, the subcommittees has continued. Just a glimpse of some of the things that have taken place since the last update. As was referenced before, there have been training videos for staff and families, cheat sheets and translated guidance related to the self-certification process. Right now, there's a hand sanitizer and thermometer drive happening. As principals become aware of families who are not completing the self-certification process, we can make sure that lack of a thermometer is not one of the reasons that that's not happening. And hand sanitizer, just kids can keep it in their backpacks, and that will obviously just make it a little bit easier access for them. All the rooms have hand sanitizer in them, but parents have been told that they can send their own in their backpack if they have a favorite one that they like to use. And just, through the drive, then anybody who we can get that into the hands of kids. BPAC is doing a pilot peer-to-peer program for parents in the kindergarten and first grade dual language program. And just really a crew of volunteers that are waiting on standby. The principals have been very intentional that they want to work through the kinks of the arrival and the self-certification process without any volunteers, because it's important that we're able to do this with no other help than us. And then once they do that, they'll have a better idea of where they might need some help on the outside of the building, and then we can activate the volunteers that are waiting to be asked. So great work all around, and I think, I can't say enough. I think I communicate an email with Katie 6, 7, 8, 9, 10 times a day with questions back and forth that I want to make sure I'm understanding things correctly and, just sharing ideas. So that partnership has just been invaluable. And even just staff questions, safety related, process related, this has just been a really, I don't know how you fit it in with everything else that you're doing, but we very much appreciate it. So that is it for this workshop.
We should just follow up with that list with a big thank you to that Pratt team. I think just thank you to everything that they're all doing.
It's terrific to have them working, volunteering that time. Thank you. Okay, upcoming meetings. Monday, October 26th, 7 p.m. regular board meeting. And then Monday, November 9th, 7 p.m. our regular board workshop meeting. Are there any items board members who wish to present for consideration to a future agenda?
I think at this agenda, we should switch 8 and 9.
We should do what?
Switch 8 and 9. I'm just looking at it now. We have them backwards on this agenda.
Oh, we do?
We do.
Oh,
So I just move we switch those.
okay. Well, very good. Thank you for that editing. All right. The board has a need to adjourn to closed session. Ms. Moak, just clarifying, is there any possible action following closed session? No, there was not. May I have a motion then to adjourn to a closed session to confidentially discuss 2C11 litigation when an action against, affecting, or on behalf of the school board has been filed and is pending before a court or administrative tribunal, or when the school board finds that an action is probable or imminent, in which case the basis for the finding shall be recorded and entered into the minutes of the closed meeting.
Motion.
Second.
Any discussion? Roll call, Mrs. Moak?
Mrs. Buttimer,
Yes.
Mr. Estes,
Yes.
Mr. Guzman,
Yes.
Mr. Lobach,
Yes.
Mr. Curry,
Yes.
Dr. Bruno.
Yes. Thank you very much, members of the community.